for this panel discussion on NHI. Since the NHI bill has been published, I think all of you know that we've been having a lot of debate, both in discussions like this and in conferences, but also in the media and probably around dinner conversations that all of you have been involved in, because it impacts every single one of us as citizens of South Africa. However, this morning we've got a very esteemed panel here with us, and I'd like us to actually zoom in a little bit and become more practical in our conversation around NHI and look at what is going to happen at a patient level, at an investor level, at a private healthcare company level when it comes to medicines and medicine reimbursement. So that is really going to be the scope of our conversation this morning. We are joined here by 4 very distinguished guests. I'll start by just naming our panelists, and I'm going to ask them all to introduce themselves to you and to make some introductory statements around how they think we should be talking about and dealing with medicine reimbursement under NHI. So I'll start off on my left here with Dr. Nicholas Crisp, who is an advisor to the Department of Health currently for NHI.
Good day. As you heard, Nicholas Crisp. I'm a public health specialist who's retired and come back to help to set up the office for the implementation of the NHI fund. So what we are doing is creating the capacity for the administration and operations to run the fund. So I think that's all I need to say at this stage.
Okay. Next we have Francisco Plaza. He is the managing director of Janssen Pharmaceutica. It is one of the pharmaceutical companies of Johnson & Johnson.
Thank you very much, Kirti. It's a real pleasure to be here with you and share the panel with the rest of the panelists, and looking forward to having a discussion, as you said, also on what the implications are for the different stakeholders on the NHI implementation, which is quite close to the Johnson & Johnson credo values of facilitating access and equity around the country. So looking forward to the debate.
Okay, and then to my right, we've got Professor Alex van der Heever. Okay.
So, I'm Alex van der Heever. I have the Chair of Social Security at the Wits School of Governance. My background is in sort of the economics and financing of health and social security, and I've worked extensively in the area of health policy, both directly in the system and implementing policy reforms, as well as in the sort of the academic environment.
And then we have Lullu Krugel, who is a senior economist at PwC.
Thanks, Kirti. Yes, I'm the chief economist for PwC in the southern market and a partner at PwC in South Africa. Our focus is in particular on fiscal issues and challenges and matters, and we advise government as well as the private sector, in terms of how do we deal with this, and we in particular deal with a lot of investors that's looking at coming into South Africa or in the rest of Africa, and I think sometime this morning we will get into the discussion around what we think NHI means for them and what they've told us in terms of our interactions with them.
Great, thank you, Lullu. So Dr. Chris, maybe I can start with you. In the NHI bill, we see that there's proposed a new single SEP system. There's also talk about a complementary cover, and there's also talk about centralized procurement of medicines. Can you talk to us a little bit about how you see that system actually being implemented, and also what would it mean for innovative medicines in particular?
Okay, thanks. Sorry, I missed the first one of the 3 you asked me about.
So the new single exit price system that's being proposed in the NHI bill.
Okay, so 3 completely different issues, I guess.
Yes.
So let's deal with them. So I think it's quite difficult to talk to these without putting in the context of what we're trying to achieve.
Yes.
So our focus is on the patient, not on who
Yes.
makes profit and who makes money and
Yes.
so on. So obviously that's the objective. So the idea is to try and get the lowest possible prices for everything that is purchased, to get the maximum efficiencies in the system, to cut out unnecessary administration, and to make sure you use the purchasing power of a very large pooled fund to achieve this. So in terms of buying services from providers, the NHI fund is set up as a single purchaser, so a strategic purchaser who can then buy from both the public and the private sector, and obviously to do that, to have the benefits described, costed, and set prices. And in terms of the medicines and the devices and the technology that is required in providing those benefits, to use the purchasing power to negotiate the best prices possible. Obviously, setting up the information systems to collect the data, to understand the volumes involved, and to do the costing of what can and can't be afforded in the system is what we're going to be focusing on in the next 4 to 5 years. As far as complementary cover is concerned, we're a long way away from that, because in the meantime, the system needs both the public and the private sector to be running pretty much like they are, with as much improved efficiencies in the system as we can. But once the NHI has the definitions and is including benefits in its funded package, then those benefits, what the bill says, will not be funded by private medical schemes. But whatever is excluded, and they may be excluded because they're deemed not to be contributing to health outcomes, or that they are just not affordable, for whatever reason that we might exclude benefits, those are the benefits that will still be provided or may be provided outside, and that's the complementary cover that is described in the bill.
Okay, thank you. So Paco, if I can come to you, what are your views on innovative medicines and how they could contribute to an NHI system and patient outcomes?
No, thank you for the question. I will say, as Nicholas said at the beginning, that the debate should start in a different angle. It's starting with what the principles behind are and what the objectives in the long term are, and namely the patients being in the center of the process, to ensure the equity around the country, to increase the access, and to ensure the sustainability of the system. And considering those principles behind the NHI implementation, what I can say is that Janssen, as a pharmaceutical innovator and as part of Johnson & Johnson, it's pretty much aligned with what we are aiming for: increasing the equity, increasing the access, and putting the patient in the middle. The second element that I think is important to consider, and this is where you introduce the question, is what is going to be the space for the innovation and what is going to be the access to innovation in this environment. Understanding that access is much more than the price, for sure, and it's a combination of accessibility and affordability. And those are the two main areas we need to work in the current environment and in the future environment of the NHI. Access to the drugs and availability. Well, we all know that in the past we have been seeing 7-8 years average on getting registrations, and we all know all the good direction that SAPRA is now taking on shorten the registration timelines. And hopefully in the near future, we will see the results of this acceleration. We are still in the process of implementation. The second element is on affordability, once the treatments are available. And for sure, it's a good starting point, having the debate on NHI to what mechanisms can we have to discuss, to negotiate what affordability means. Because being the principle, not looking at a particular price, but to ensure the patient being in the middle and the affordability for the population as a whole, the price is not the most important element. It's the affordability of a therapeutic area, for instance. So this is the element we need to incorporate into the debate. And the third element in the debate, obviously, is the devil is in the details, how the transition is going to be, how are we going to move from one system with areas to improve, but also with good points, to another system, and how long is it going to take, and what the steps we need to take are.
Okay, Thank you, Paco. So, Alex, if I can come to you as a specialist in health economics as well, what are your views in terms of how these issues should be managed?
Yeah, so firstly, you don't need a national health insurance arrangement to sort out drug policy, pharmaceutical policy and regulation. So when you look at the SEP framework, the SEP framework hasn't been evolved by the Department of Health in 20 years. Nothing substantive has been done apart from what was introduced in 2004. And the environment remains, the whole framework remains unsophisticated, weak, and riddled with holes. So let's look at one aspect of it. So I've just recently supported research in looking at the price volume distributions or at SEP prices within sub-markets, basically by molecule. And what you find is a huge array of price disparity, price variations. And what does that tell you in the SEP, in the private market? What that tells you is that certain products sustain very high volumes at very high prices when competitors at lower prices have low volumes. That's an irrational result. How does that occur? Well, I'll tell you how it occurs. It occurs because we have essentially institutionalized kickback mechanisms operating that segment the market. This is well known. This is known throughout the market. It's not a mystery. It's also known to the pricing committee and those discussions, and yet nothing is actually done to review that and to say, well, what would we prefer as an outcome? Now, the NHI proposal, as Nicholas has described it, relies on kind of one option. We will be a monopsony purchaser. We will be a great big ESCOM that buys medicines, and that will somehow solve complex problems of price setting, volume distribution. Now, I'm going to give one example. The state already has huge monopsony power. It already is a major purchaser in the system. And I'll give you one example. Somebody recently, one pharmaceutical manufacturer, was indicating to me that when they tender in the state tender system, the first thing that happens is they've tendered on the basis that a certain volume will materialize, and it doesn't. So they've actually dropped their price on the expectation that they will have 40% more volume than they actually pick up. And that is the assumption. That's effectively what's been indicated would occur. And then secondly, the provinces don't pay. So effectively, the provinces are borrowing from the pharmaceutical manufacturers. So they say it's not actually worth their while to participate in the state tender system, but they're worried about just withdrawing from the state tender system because they're worried about being blacklisted. Now, there's no coherent framework in South Africa. There's nothing that says that government can somehow blacklist somebody for not participating in a tender. So what does that imply? It implies that government officials and politically appointed individuals apply a discretion in the way they operate tender systems in South Africa. Now, that's a huge problem. Now, I've seen, because I was on the pricing committee running the SEP framework, I know all the holes in that framework and that system, and I've seen when the Department of Health chooses not to correct or close those holes, when stuff disappears into a hierarchy of decision-making in which some politically induced decision or individuals who are influenced based on proposals sometimes made to them personally and sometimes appeals to the ministers directly, stuff just does or doesn't happen that bears no relation to any kind of policy logic or rationale. So now those in the two different environments, the tender system as well as in the SEP framework. So there's clearly a problem. Why does the policy not evolve? Why does the obvious stuff not get handled or addressed? And a lot of it comes down to what is essentially in our existing framework, a patronage system that operates. Where at the end of the day, as Trump has done with Ukraine, somebody says, you want this tender? Give us this donation. Give us this amount of money. Give me this job. Give this friend this job. That type of stuff is endemic within our current system, and it's the reason why our reforms don't happen. So when we now look forward at the institutions that we need to regulate the pharmaceutical system, it's not about saying we're going to have a fantastical monopsony purchaser who's just going to solve everything because they're a big contractor, because if that were the case, Eskom would have solved the problem of energy production and energy distribution. And lo and behold, monopolies don't solve those problems, because any permanent institution, something that has an indefinite life that is effectively funded by the taxpayer, doesn't have to work very hard to survive. That's one of the fundamental problems of governance in any institution. So when you design mechanisms for policy, you look at multiple ways in which you can have accountability seep into the decision-making and affect the incentives of those bodies. Now, right now, we don't have any policy on the table to look at which regulators for pharmaceutical pricing, for actually the economic aspects of pharmaceutical production and distribution and pricing would actually occur in some sort of rational framework, which involves a combination of markets that set prices efficiently and fairly, plus government that buys products in an efficient manner that isn't corrupt. And just one last point on when governments' procurement systems for medicines and multiple products could face the risk. So let's say we don't have the corruption in the system. We have a top team of people, which is hard to imagine at this point, running pharmaceutical procurement in South Africa in terms of government procurement. They have a top team. The next possibility that you have is that you actually eliminate, people exit the market because of single winners in major tenders for long periods of time. So how do you maintain competitors in a system with single winners? You've got to have multiple winners. So how do you maintain effective pricing with multiple winners? How do you make those decisions? How do you keep the system vital? How do you get local production to come into the system and bring that into your decision making and into your pricing models? It's complex. That complexity currently exceeds the capacity of the Department of Health at this point. I'll make one further point just on IP arrangements and stuff like that. It's also been identified as a major area that has to be looked at. The extended patent periods, what's the logical approach in South Africa? We've had legislation to allow parallel importation. We've had in the SEP framework the consideration of international benchmarking. None of those things have been implemented despite the fact the legislation went through in 2002. It doesn't matter that the policy in itself may not have been entirely coherent as it stands in the legislation, but what you'd have expected is that there's an evolution of attempts to implement policy and repair them. But what you have is just long periods of time of nothing. And this, to me, is a problem because it's not exclusive to pharmaceutical policy, medicine policy. It's pretty much rife. And my concern on the NHI is people talk about, no, wait until we've got this office going, and then we're going to have some people there who we think they know what they're doing. They're going to solve the problem 3, 4, 5, 6, 7 years from now. The reality is all these reforms can all be incrementally advancing at any point in time, but there is no team.
Thank you for that, Alex. So Lullu, if I can come to you. There's a lot of different initiatives happening more at a broader level within the government. Alex just mentioned IP as well. We don't really have a coherent government, South African government position on this. You've got DST talking about building a knowledge economy, talking about R&D incentives, trying to attract more investment in R&D. We've got DTI now talking about developing a health economy master plan, trying to drive more investment into the healthcare sector. And then we've got, of course, all of these discussions happening around NHI. Can you share with us some of the conversations that you're having with both local and international investors and how this is driving investor sentiment and in what direction?
So one of the key things that we're seeing coming out at the moment is if you look, first of all, from a local perspective, if you look at business confidence and investor confidence, it is at its lowest point in about 15 years. So there seems to be a bit of a disillusionment. I think in the beginning of last year when President Ramaphosa was appointed, we saw a bit of a revival in business confidence and people saying things are going to turn around. I think what has happened since is from an economic and fiscal perspective, we realized that the hole is a lot bigger than we thought, and it's a more significant challenge that we actually need to sort out. So I suppose on the one hand, we need to have a bit of patience in certain areas, but on other aspects, I think the general South African public is a little bit frustrated, and business feels disconnected. And the reality is that we really do need private sector investment to get the economy going. Government does not have the bandwidth and the funds and the money available at the moment. We heard in the October mini budget that we expect the budget deficit to be over 6% in February. The overall debt to GDP ratio to increase to over 70%. So it tells us that we will actually have to cut expenditure, and we will have to be a lot more innovative and efficient with our money. Because to be quite honest, I don't think South Africa has a problem with the availability of resources and money. We actually have enough, but we haven't been very clever in terms of how we spend it. And we also think that funding is the one thing that we need to solve all problems. And sometimes it's not that. And I think internationally we've seen, if you look at healthcare outcomes, for example, that funding is a proportion of that, but other initiatives like education, like market access and so on, also play an equally, if not more important role of just throwing more money at the problem. And I do believe that there is an understanding in government at this point in time to say, but we know that we have limited resources, we need to work with what we have. In terms of our experience, if we think about engaging with government, we've definitely seen a change in terms of being more open to listen to investors. So they tell us, please come and share with us what your investors, what potential investors are saying. Please come and tell us what are the challenges for them. And there are definitely certain pockets where they're trying to remove some of those issues. But if you look at, as I said, from a local perspective, we need to get business confidence back, and probably one of the easiest and most important ways to do that is through policy certainty. And NHI and land reform and the mining charter, and the list just goes on about getting clarity around that and how that's going to be implemented. And then if you look at international investors, some of them are a little bit more forgiving in certain aspects. They're saying we're willing to work in a bit more ambiguity, because some of them that are multinational firms, etc., have worked in environments, where there's a bit more ambiguity, but still they're making decisions for the long run. So if they decide to come to South Africa, they want to know that they're going to be here for they know they're going to be here for a couple of years, and they want to see that there's an opportunity and a possibility for them to get returns.
Okay, thank you. So Nicholas, if I can come back to you, if you could respond to some of the statements that both Alex and Lullu made. In particular around, you talked about the patient comes first, and I think no one would disagree with that statement at all. However, the NHI does not exist in a vacuum. We still need to think about the fact that companies are operating within the economy. And, the monopoly, the system that Alex was referring to will impact market competition, and that is going to impact investment and investor confidence that Lullu was talking about. Alex also talked about the SCP system, and he had some strong views about that. So maybe you could reflect some views and your opinions about that.
Sure. Okay, thanks very much. First of all, we're discussing pharmaceuticals specifically because that's the forum here. But that's not the reason why the NHI has been embarked upon. Of course, it's one of the products that is used to service and provide a service as a pharmaceutical product.
Yes.
And I didn't answer the question about innovation. When I spoke to the Innovators Association, the same question was asked. Innovation is not always more expensive. If you don't do the health technology assessment, and you are not comparing apples with apples, then it can be assumed that because a price is higher, it's more expensive. But the point where we've been trying to make quite a lot is around, for instance, a pharmaceutical that is a single daily dose might be more expensive, but you're going to get better compliance, better outcomes. So it's about the outcomes rather than just the unit cost. So I mean, I don't think it's as clear-cut as innovative medicine is always the most expensive and therefore you're going to be cut out of the market. It's not like that at all. And I think the need for health technology assessment, which is seriously lacking in South Africa, is something that we will build very strongly into one of the units within the NHI office. We talk very easily about the general South African public. There's no such thing as a general South African public. We've got 45 million people out there who are very ripe for revolution. We see, I came back from Nelspruit on Tuesday and had to take a massive detour because people are burning tires on the N4. You came down another road now, the SAA staff are barricading the road here between the two hotels 6 minutes apart, and I had to go around again. You know, every day there's some kind of unhappiness about something. And the general South African public we talk about in forums like this is a very small portion of the population, albeit the rich portion of the population who pays the most taxes and who does control the economy. But we must not lose sight of the fact that people are very angry because they're not getting services and they see others getting the services around them. So I know that we've got low business confidence. I think we all know that. We know that there's this massive debt that has been created by fraud and corruption, and we're starting to see action. Every time we watch the news these days, there's another revelation of the Zondo Commission, and now we hear Shamila Batoy talking about finally getting ready with Estina and so on. So we live in hope that we can start to turn the tide. But we are South Africans, we live here. Are we just going to accept it and say, well, you know, it's fine, everything can continue like it is? I'm happy with my 11% increase in my medical aid scheme this year. Even if I got no increase in my salary, I'll get by. It's not okay. It doesn't have to be like that. And it's not appropriate. The services that we are delivering are not appropriate. We don't get the outcomes for the investment we put in. Are we prepared to tolerate a government where 9 provincial departments basically do what they like? We formulate policy. Alex complains about we don't implement policy. They don't have to, because there are 9 different governments who ignore what the provincial government, what the national government agrees to in many instances. There are many, many things that we have to fix in society. There was a worry about eliminating people from the market and forcing them to exit the market. That's not my understanding of what the intention is. The intention is to negotiate a price, and then anybody who can provide at that price, the purchasers, the service providers can buy from anybody who provides at that price. And if you can make a bigger margin on the difference between your cost and the price, then you do better than somebody who can only make a smaller margin because their costs are more expensive. And obviously one needs to negotiate that in the marketplace. This morning there's an article in the media about how competitive are we with 50 other countries around our medicine pricing. And it's not too bad, but it's also not good. We're not the most effective. So look, I don't deny that there are all kinds of problems. And I don't deny that without changing the system, there are some things that could be changed. But to get the kind of equity that we need in this hugely inequitable country that we live in, by just fiddling with the edges or maybe tightening up on some of the policies, personally, I don't think that's going to cut it. And I think we do need a major overhaul of the health system. But Alex made some quite direct allegations about basically collusion, corruption, and deliberate manipulation in the pricing committees and so on. You know, if that hasn't been reported and formally raised with the SIU or at the Zondo Commission or wherever else it needs to be raised, I think that's, you can't make those allegations in public if you are not prepared to raise them in that way in the formal processes that are going to deal with them. And if there's evidence of that, as a taxpayer, I would not tolerate that either. And I would be very keen to hear more about exactly what it is that is being done in terms of that collusion and that collaboration. We need to fix our systems. And we have chosen the NHI as the route. Well, the politicians have chosen it. And I've chosen to come back into the public sector and assist, because I've fixed things before that everybody said can't be fixed. And they can be fixed. They take a long time, deliberate, diligent effort, and currently exceeds the capacity of the department. The department is on its knees at the moment. It's been on strike for 2 years. It's a disaster. They know it, we know it, everybody knows it, but we're not talking about sustaining the current capacity of the department to be able to fix our problems. There's a lot more work to do than that. I think I must leave it at that.
Alex, you want to
respond? Yeah.
respond to that?
Yeah, so let me give one example. An international benchmarking report is produced by the Pricing Committee and submitted into the Department of Health, and it just disappears for 2 years, and thereafter and beyond, nothing happens. The issue is that these are parts of, now why does that occur? So one can only speculate. It's not necessarily corruption, but it is highly suspicious. The issue is that there's more than that. There are policies that are put out that deal with institutionalized corruption in the private sector, regulations to deal with that, they disappear into the ether. That's part of the policy-making process. Now, there might have been concerns with the specifics of those policies, but that's not how these got resolved. These got resolved in a murky way that's problematic. Now we're dealing with instances where we're talking about organizations that are responsible for procuring massive amounts, massive volumes of drugs, pharmaceuticals, and other health services. So you talk about the rioting in the streets, and SA Airways on strike. Why are they on strike? They're on strike because their organizations were involved in what I would call institutionalized corruption. It's not just bad apples. It's not just some mistake that was made in an appointment. It is institutionalized. It's a whole system that generates the corruption that has driven every single state-owned enterprise into the ground, and now we're talking about another equivalent version with the similar governance models that will inevitably result in institutionalized corruption. And you cannot create organizations with massive amounts of power and not put in protections. And the first problem that you get with creating institutions that have a massive amount of power is you put all the power in one box, one place. You concentrate it. That's why monopolies tend not to be efficient. That's why they tend to fail. So the issue is, what is our systems architecture that, first of all, does not institutionalize patronage and corruption? Now, to go on the comment on the provinces not doing what National wants. Sorry, National has the ability and has had the ability since 1994 to create institutional frameworks through national legislation. It can determine accountability structures at a provincial level. It could have intervened on whether or not hospital structures involve political appointments. It could have done that through the force of legislation. It's not somebody saying, I recommend you do something better than what you're doing, please behave. It's not, please implement this guideline. National government has the ability to introduce conditional grant structures, legislative frameworks. It can influence lower levels of government. But we also have to look at why is there such a fundamental structural difference in performance between the Western Cape and the other 8 provinces, and ask, well, what's common to those other 8 provinces? What is common in those provinces is that people no longer run those provinces for the people. They run them for the politicians and the political structures. They have been part of a system of institutionalized corruption pretty much the same way as SA Airways. And it doesn't matter that it's national, like SA Airways, a national function. It's a provincial function, runs the same. If you have the same conditions that allow somebody to appoint people without merit and not be held to account for a failing system, then that's expected, an expected result. So what we're not seeing, for instance, in the NHI proposals, when one talks about putting huge powers of procurement for medicines in the NHI fund, what's the governance structure around that? Everybody's appointed by the Minister of Health in a centralized organization. It is absolutely 100% predictable what would happen. And I'm afraid the example, Zondo Commission and the rest that we're seeing now, we are fragile in terms of our structure because every part of our state system involves political appointments. We have no protection if suddenly this president shifts and somebody deeply corrupt comes in, everything turns. Immediately then, no institution is protected. So we have to build institutions that are insulated from predictable corruption. predictable institutionalized corruption. And I have seen no intent in this process to create these structures in healthcare that have power, that's regulators. And we're seeing now, if we look at the Council for Medical Schemes, a body that I helped put together and set up, they've just taken the entire top management of the Council for Medical Schemes and said in March, your contracts are all terminated. And everybody in the council and the registrar are political appointments, and they have every intention of replacing the top management of that structure with political appointees, and it's a pure political route. What's the difference between that and what's been done at SARS? So fine, some institutions turn around because the president focuses on them and deals with them, but the rest... So you cannot have public bodies, regulators, and regulatory frameworks subject to this discretion. And just a comment on the issue of the, because I failed to comment on the complementary cover issue, the so-called arrangement in the Act that would say that medical schemes wouldn't be able to cover whatever the NHI fund covers. Well, I'd love to see that one get through courts. It's never going to survive. First of all, there is no reasonable prospect in South Africa's future that the so-called NHI fund will provide anything better than what the public sector currently provides for the foreseeable future. That's basically for our lifetimes. And even if it were able to provide something vaguely decent, the idea that it would actually be something that you could actually say, no, we're not going to allow you to compete with our NHI benefits. We're going to prohibit it the way Eskom prohibits and has for many years prohibited competition with production and distribution as a way of so-called getting efficiencies in our system is absurd. It will never survive a legal challenge. I'm perfectly happy to have that one in court, but the issue is we will be dead by the time we will have to have the court case because it's just never, ever going to be implementable. So I think that going into the future, the issue is we are stuck with the systems that we have. We have to reform the provincial governments. We're not going to wait for an NHI fund to do it, and we have to reform how the private sector operates, and there is no point in waiting for an NHI fund to do that, and currently there is no process in place to reform either.
Paco, you wanted to make a comment?
Yeah, no, thank you, Kirti. It's obvious that funding, the economic model behind, and the sustainability of the NHI implementation is a key topic. But then, as you said, we need to put into the perspective. It's not about the pharmaceuticals. It's not about the innovation. Actually, the pharmaceuticals are going to represent a relatively minor part of the total budget. And we all know that human resources, infrastructure, and the normal functioning is much more than what the pharmaceuticals, innovative or not innovative, is going to be. Currently running around 8 to 15% of the total cost, depending if we see private or public sector. So the total cost is not around pharmaceuticals, it's around the sustainability of the system, and this is where the debate should be. Then it's about costing. 80% of the treatments in the country are around 16 therapeutic areas, and the average price in those is 150 rands. So it's not about the costing of most of the therapeutic areas, that actually in those therapeutic areas, the savings generated by the generics introduction, it's giving a space for the innovation to come. And the third element there is when we compare pricing with other countries, and you mentioned the article this morning, well, South Africa is the 6th lowest country in a basket of 15 in terms of pricing. Is there room for improvement? Yes, for sure. But the reality is that when we look even at the single asset price to 13 molecules in South Africa, the price as compared to the median of those countries is 50% lower. So we have a good starting point. The question is, in the current environment, and particularly in the future environment, what else can we do even to increase affordability? What else can we do to have those negotiations? What else can we do to implement innovative access schemes? What else can we do to ensure the affordability for the population as a whole? And fully agree with you, Nicholas. It's not about the costing of innovation, it's about the impact it's having in patients. And an independent focus on outcomes, HTA, will potentially help if really is independent and if it's really focused on the outcomes rather than pricing model. So fully agree that we have a good starting point, that there's a lot of margin for improvement, and the collaboration among different stakeholders with the right flexibility and mechanism to implement this flexibility can help a lot. But the debate around funding is by far not about the pharmaceuticals or the innovation, is the system as a whole.
Lullu, any idea?
Something specific that you... Sorry. I think what I just want to say, it's really nice to see people that are so passionate about South Africa and the healthcare system. Although we don't necessarily agree, I think we all agree that there are things that we need to fix for this country and for everybody that lives in it. And we certainly can't accept that we're just going to continue in the same vein. And I think if we're having debate, it's a good thing. Around the affordability and the funding aspects, I feel at the moment, we tend to get a little bit stuck in a particular solution, and if we can't get there within a particular time frame or get to what we set out to achieve in a particular time frame, we think we failed. And I think given where we are economically and as a country, it's time that that government and this public sector and the citizens of this country engage with each other and say, listen, this is what we can do at this point in time, but it will also mean that some of us will have to give up and there I count myself in some of the comforts that we have, at least for the time being, to be able to fix certain things. But it also means that from government side, if you look at government expenditure in general, I mean, the expenditure about 40-50% is going towards salaries. We know that the Minister of Finance said that is one thing that we need to address. So it is absolutely crucial that the way in which we structure our spending as a country at the moment is one of the first things that we need to relook to be able to unlock money for the areas that's really necessary for economic growth, things like healthcare, things like infrastructure, etc. And to be able to do that, we really need to rethink, how we spend our money, and that would mean perhaps cutting salaries on the government side, maybe something that's really not popular. And I also understand that there's, Nicholas spoke earlier about the SAA employees that are frustrated. And the ESCOM employees that are frustrated. Some of us look from the outside and you say, well, they just need to realize we have to do that. But in a country with almost 30% unemployment, if you are one of those people in that position, you look at it through a different lens. But bottom line is we will have to renegotiate and rethink what we're doing with our money, how we're spending it. The Minister of Finance went back to the government departments and said, please, can you cut your spending by 5%? And by that, he didn't mean like spending that's really necessary. It meant, areas where we can potentially reduce, and be more efficient. And eventually they came back and said, we're willing to do 2%. And I think we need a stronger stance from government to say, we're not asking you to, you have to, for us to be able to actually do the things that we need to do as a country and address some of these challenges, whether it's the NHR, whether it is whatever we need to do.
So Nicholas also made a very strong statement about saying, let's not only talk about the few taxpayers, we need to be talking about the broader population of South Africa, and I think that's a very valid point. Paco also talked about increasing access and affordability of medicines to the broader population. What is your advice to the few of us that Nicholas was referring to in terms of austerity measures?
Yeah, I think, let's be honest, our tax base in South Africa is not large enough. We need a larger tax base to be able to do what we need to do. And there's about 600,000 people in this country that pays about 75% of the payroll taxes that we pay, so personal income tax. So obviously that is not a sustainable situation, and I think government also realizes that, National Treasury definitely realizes that, and they've said very firmly that, you know, we can't just indiscriminately continue increasing taxes, and if it's not personal income taxes, maybe tweak here and there. At the end of the day, it increases the tax burden on that group. So I think there's a lot of frustration in that specific part of the population as well, because my view is that most South Africans realize that we live in a country that is unequal. We live in a country with a history that's created challenges that we need to deal with. And if you're here, you are buying into to say that I understand as a taxpayer in South Africa, my situation will be different than somebody in Norway or in Sweden or etc. But where a lot of the frustration comes in at the moment is the feeling that I've paid this hard-earned tax money and I'm not feeling that it's being spent in a way that's efficient and that addresses the challenges that we have as a country. So I know SARS, for example, is working really hard to rebuild trust, you know, to see how they can, as an organization, transform themselves so that people feel that their hard-earned trust money or tax money is going not into a black hole. National Treasury, the Minister of Finance, his budget speech was actually very firm to say that, you know, we can't continue in the same direction if we want to address the 30% unemployment. If we want to address the fact that we're the most unequal country in the world, we can't continue in this direction. And I just hope things like the Moody's negative or change to negative outlook that we've seen might shake up some of the politicians and say we need to support. You know, if we take a direction, we need to support this direction and just pull all in one direction.
Okay, thank you. Nicholas, you wanted to make a comment?
Yeah, thanks very much. Look, I think we can be excused for being a bit cynical and a bit cross with our government and negative at times. But I think we've reached a tipping point. And I'm an eternal optimist, and I think I like to believe I'm pragmatic, so I like to find ways to solve solutions. So there are many problems, and some of them are acute, and some of them are going to be with us for a long time. We have to manage them out. But, you know, if we make broad statements that sort of impact and say that people like me who are being recruited back into the government service as a political appointment because I'm going to be involved in corruption, you can go and check my track record. How many people have I reported? How many people have I disciplined? How many people have I put away in jail? How did SAPRA's SIU appointment happen? You know, these are things because of people like me who come in and say, enough is enough. So we can be cynical and we can say everybody is going to be a political appointment in CMS. Or we can say, well, maybe some of the people who have been, whose appointments are not being renewed in the CMS is because they weren't competent to do their job and they didn't do it effectively, and there are going to be jobs advertised and other people are going to come. But you can't preempt the decision to say they'll all be political appointments. We have to start being a bit more positive than that and engaging in the system. Well, that's my view, and Alex and I differ on a lot of things, but the other things we're quite happy to work together on. That's one thing we will just have to differ on. But there are things around the implementation. So I see the implementation of NHI and facets of it quite differently from what I'm hearing. So I don't see the nationalization of the delivery of the healthcare system, which is what I get in some of the conversation and some of the rhetoric. Private providers will still provide services as private providers. Mm-hmm. So I don't differ that we have to fix the private sector. The things that have come out in the health market inquiry, we've all known since before the whole health market inquiry started about the levels of monopolies that are there, the large size of some of the major players distorting the market. We know all of that. We knew it long ago. And yes, government could have done something about it and should have regulated it. But it doesn't help to harp back 10 years or 8 years or whatever. We've got to say, okay, so now we must fix it. And Alex is absolutely right. We need to fix the private sector now. We need to fix the public sector now. There are parts of it that are a mess, but it's not all collapsed. You know, a reporter says to me the other day, the whole public sector's collapsed. Nonsense. People are still getting valve replacements, people are still getting good health care, people are still seeing good specialists, there's still cancer therapy going on in hospitals, there's still health care. 45 million people still use the public health sector every day. It's not optimal. And there are parts of it incredibly badly managed, and there is theft, and there is manipulation of tenders and things which bother us, but we must report them, not just note them and say, well, it seems suspicious. That's not how those officials got suspended in SAPRA the other day because I thought maybe they were suspicious. There was a whistleblower who complained. It was investigated internally, and the board asked the minister to ask the president to appoint the SIU. The same happened in NHLS, where there was suspicion of some activity. We could have just said, oh, it's very suspicious. No, it was way too suspicious. So the board asked the minister to ask the president to appoint the SIU. That's what happens. You act. And if you don't act, you live with the consequences. So, I think that the time for sort of focusing on the past, we need to focus on the past just to avoid doing those things that were done in the past into the future. But what we have to do is now focus on how we're going to fix things into the future. And the NHI is not going to procure all the medicines in the country. This is not a logistics outfit. It's a setting of prices. And that unit need not be in the NHI office, but it's been put there in the bill. If it gets removed and it gets put somewhere else, somebody must still do it. So whether it's a separate entity or it's in the Department of Health or it's in the NHI, it will not be the logistics office that is buying the medicines. There won't be tenders anymore. Once the price is set, if you're an accredited provider, you will buy at the price. So it is setting the prices that is important and making sure that the choice of what gets onto the EEL, what gets onto the essential equipments list, what gets into the technology that we use is appropriate. We have to do things differently. If we keep doing them the way we've done them up to now, we're going nowhere. We work very closely with Treasury on a whole lot of new ways of doing things. So in the government, there's a mechanism of conditional grants to try and steer various policies. Alex alluded to that. Well, if you're me, I would say that if you need a conditional grant, it's an admission of a failure of the budgeting system. Why do you need to have a conditional grant nationally to force the provinces to do their work? You should have a policy and they should execute those policies within their budgets and they should get the money in their budget, surely. We have 14 conditional grants in health at the moment. That's as many as the rest of the government put together. It's crazy. We have such a big administration just administering conditional grants. Crazy. We have 2 infrastructure conditional grants running in parallel in the health department. Why? This is inefficient and it does not promote national planning and national policy and national implementation. We need to get rid of the conditional grants and we need to run the system as a system, not as a whole lot of little bits and pieces all over the place. Lullu mentioned about cutting salaries. You're not going to get that right. There's too much of a political arrangement with Labour and the government around that. But it's time to put a brake on salary increases, that's no doubt. And the one way to do it, and one of the things we're looking at now with the health department, even from where I sit in the putative NHI fund office, is how do you refine the benefits? And are your policies actually helping you? So for instance, why do we insist on 2 years of internship for doctors when we can't even afford to employ them for those 2 years because we don't have money on the budget? Are we adding value by making them do 2 years of internship? My sense is it doesn't really make a huge difference. So we need to investigate that and maybe terminate one of those years. Do we need all this community service we're having, or is it just sympathy because we made the doctors do it to get more doctors into the service? Do we get better outcomes because of the community service project? And if we don't, we must stop it. Then we don't have to employ those people. Or we do what they do in Nigeria and we say to the private sector, you may employ these people to do their community service before they go into full-time practice. You pay their salaries, here's the conditions and you report, and it's part of their training. Why are we doing it? So there are lots of these small things where they've just been allowed to mosey along and they've been there, and many times we've forgotten why we put them in place in the first place, and they're costing us money. RWAPs, allowing, on our tax money, allowing our practitioners to use our time, not their spare time, to go and see private patients and to care for private patients in private institutions for private gain, while we are paying them a salary and they're supposed to be either teaching our students or seeing the patients who are in the 80 to 85% group. Why don't we clamp down on them? Bad management, bad this, bad that. So those are all the things that have to be tidied up. So I would put it to all of us. Everybody must sharpen their game. Everybody. Private delivering, service delivery, private financing, public delivery systems, pharmaceutical suppliers, assessments of HTA, everything. It's not either or. It's not fix the public sector, and when you fix it, we'll see if we can maybe fit in and try and shape the shape of the private sector. And it's not fix the private sector, it'll solve the public sector. Everything needs to be fixed. We have a mess at the moment, and we need to fix it. Nobody's coming to fix it for us. And if we end up with World Bank or IMF or somebody coming in telling us what to do, woe betide us.
So, Paco, if I can ask you, Nicholas made some really interesting points. And I think some of them speak to innovation, not in terms of innovative medicines, but just innovative ways of looking at some of the challenges. How do you think the private sector can play a role in contributing to some of these solutions?
Well, I think it's a moment for the dialogue. So the only way of moving forward, we know where we are, and probably we know more or less where we want to be in a certain time. So the question is to dialogue, to ensure that all the stakeholders, including innovative companies like Janssen, are part of the dialogue. Because we have many examples all around the world on how this innovation can be in the discussion and in the table. And I'm not referring particularly now to medicines, but everything related to healthcare is subject to the dialogue among all the stakeholders. And I think the relevant point is this is the time now to build together. I think probably this is the most important point for me listening to the panelists. Is we know where we are, we know more or less where we want to be, we all know that there's a journey and there are things that need to be fixed both in the short term and in the mid-term. Some of them are going to be quite difficult. We have more questions than answers in many aspects. But the only way is dialogue. And ensuring that all the stakeholders are in the table.
Okay, great, thank you. Alex, you wanted to make a comment?
Yeah, so I mean, there are a couple. I mean, I think that first of all, when we look at the problems that we see in the health system today, who caused them? I mean, I know when RWAPs came in, it wasn't stopped by government. It's not been regulated. The reason why it's abused, and there's moonlighting, systemic moonlighting of nurses within the system, you have to look at how those hospitals are managed. Why do we have the medico-legal problems that we have? Why do we have the problems with maternal mortality, with cerebral palsy cases within the system? All of those are a consequence of poor management. Then you look at just something like hospital licensing, private hospital licensing. The growth, the number of ICU beds that provincial hospitals have been approving mean that we have ratios in the private sector that are nearly 3 to 4 to 5 times those of Switzerland. Those are public provincial departments doing that. So where's somebody been watching this? When I went to look for even data on the National Department of Health website on basic information on a health system, I can't find it. So who's sleeping up there? So when these things and these policies don't change, it's because we actually do have people who are not doing their job, not being held to account. When provinces don't function, it's because people aren't saying, that's wrong. Why do we have 50% of maternal mortality in the Oliver Tambo region of the Eastern Cape? Perhaps we should send in a team. No such turnaround team goes in. So the issue is the interventions and the problems that we see aren't the general public or the private sector. Government hasn't done its job, and government needs to do its job. So in terms of the conditional grants frameworks, this is a background. It's part of conventional multi-level government systems. Every country, you'll have them in Australia, New Zealand, you're going to have them in Canada. That's how you deal with the differences between priorities between national and provincial. It's not a failure of a system. If you introduce a conditional grant, you might have spillover problems, people coming from one area to another. You might have a national function that a province has no incentive to fund itself, so you provide a national allocation. The question is, has national government been doing its job in actually working out when it should have a conditional grant and when not, and when to revise it? So, for instance, the National Tertiary Services Grant or the Health Professions Training and Development Grant were introduced in 1997 after the new constitution came in, on the idea that they will be reformed within 2 years. And I still remember that discussion, and Nicholas will be aware of my comments on this, is that after the meeting with National Treasury when we set up those grants, somebody from National Treasury phoned me up and said, sorry, I can't remember why we agreed to 1 billion rand on the Health Professions Training and Development Grant. And I said, oh, you've forgotten what we said in the meeting. There's no reason. We just made it up. We had to have something. It needs to be changed and repriced within 2 years. Well, from then till now, the National Department of Health has clearly been so busy with meetings in Geneva and so on, that it has never actually repriced, redone, recalibrated those grants and converted them into something that is useful in the public interest. And that's just a proxy indicator for how policy is being made in South Africa. It's not just unique to the conditional grant. So your conditional grants are a normal function of a well-performing government if they do their job. When they don't do their job, you have stupid conditional grants and you have provinces who run away with the money. We also have a situation where we have irregular expenditure levels at the provincial level and national level and within state-owned enterprises. This is not a provincial issue, it's everything run by government. Why do we have them? The Auditor General has announced them. He's basically saying, and when I've met with him, and asked him why there is no action, what can he do? He says, basically, we provide this information. Theoretically, all of these are flags for the National Prosecuting Authority and the Hawks to go in, not the SIU, which is a politically appointed investigative structure. You want independent investigative structures to go in. Why don't they go in? Why? So I want to sort of make a comment before I just deal with the innovative medicines issue, is that what are we dealing with in South Africa at the moment? We're dealing with systemic problems. Not one bad apple here and there. We're dealing with systems problems. We need to change systems. We need to change the mix of organizations, regulators, financing mechanisms, and you cannot change all of them at once. You have to change them on an ongoing basis with really highly motivated, smart teams, not the kind of people that we're dealing with at the moment. And that's not a comment on Nicholas.
So, I just want to give the audience also an opportunity to ask some questions. So are there any questions in the audience? We've got one there. Sorry, the lights are quite bright. I think there's one at the back.
Thank you very much. It's quite strange, but maybe not exactly strange, but I hear a lot of negativity. I mean, I really can't understand why. Who's being protected here? It's extremely negative, I'm being honest. There's a lot of corruption in the private sector, unprecedented, and no one says anything about it. Are we not trying to protect pharmaceutical companies at the expense of our own people? Now, comparing South Africa to the world, that's fine. I like that, because we need to pick up best practice. But if that best practice does not get aligned to our situation in SA, compares to Switzerland, that's fine. I don't have a problem. But let's bring it back home. I mean, if you look at our employment equity legislation, it's literally a copycat of Canada, if you read through the Canadian EE. But it was tweaked to suit the South African context, and we like that. I mean, take black economic empowerment. I mean, that legislation is taken almost word for word from Malaysia. Very successful, but it was tweaked to actually meet our South African sort of context. So what I'm hearing, honestly, is negativity, and I'm not hearing where to then from here. And that's really my comment.
Thank you. Oh, as well, I agree with what Trevor is saying. I think we only left with a decade. What we need is solutions to the medical sector. Looking at private and looking at public, I have experienced both. And I'm 100% sure that we need solutions in the private sector as much as we need them in the public sector. I've traveled the world as well. And, you know, I was in Canada and I got sick and I did not get the help that I normally get when I go to Baragwana currently. We have the skill in South Africa. We just need proper policy implementation and proper service delivery. And then we are able to get where we need to in 2030 and beyond that. Sitting here and listening to arguments, what we should have done wrong and what we should have done right, will not help us. We are here today to try and find solutions to the pharmaceuticals. I don't know medicines. I don't know how, when I get to the pharmacy, I just say, I have tonsils, what is it that I need to get? They'll know you need to go see a doctor. I mean, by now, in this day and age, in other countries, you get there, you sit down, there are nurses there that can assist you. You don't always have to be going back to the GP and consulting, which could save me a lot of money. I don't have money. We are here reading about insurance. When I hear the word insurance, I'm thinking of a premium. I don't have money to be paying for this fund. All I need is, I need to make sure that everyone else who is able to afford basic healthcare is able to, and everyone else who can afford, a basic medical aid is have access to that. Instead of me getting to a pharmacy and now being told that you can get this, but if you need this, you can get that, but then the ingredient is the same. That's all that we're asking for.
So I just have two questions. The first is, in the current political climate that we're in, does Nicholas think that the NHI is practically possible within the next 5 to 10 years, which is what I'm assuming the government would like it to be implemented in, taking into account the state of the ruling party, etc., because obviously the NHI will not exist in a vacuum. The second one I wanted to know is there anything that corporate South Africa can do to support the NHI implementation, even outside of the medical industry? So we're not just talking medical schemes. Broader corporate South Africa, is there anything that they can do to support the implementation of the NHI?
Okay. Yeah.
Okay, thanks very much. Excellent questions, and very happy with those comments. Yeah, as you gathered, I also am very positive. I wouldn't have come back if I wasn't very positive. Can we implement the NHI? Obviously, I believe we can. I think if we try and do everything for everybody all at once, it's not going to happen. But if we do it incrementally, and we build with what we've got, and we have a substantial base, we improve the way we manage, we improve the efficiencies in the system, we do away with the inequities, and unfortunately I haven't now made the presentation to show how we are building the system, not just what's in the law, but what exactly we are trying to do to build the system. I believe that we can definitely implement the NHI. Can we do it in a time when the economy is low? Most countries have embarked on some form of national health, either system or insurance or changes, massive reforms, exactly at the time when their economies are bad. They take a long time. You don't make massive changes quickly. Somebody asked me last night, why don't we just do away with all the tax subsidies now and use that money to get the NHI going? The answer is because we will precipitate at least 1 million people leaving their medical schemes and having to be cared for in the public sector overnight, and that would make things worse, not better. So you have to move these things slowly over time, and you have to put other things in place, and sometimes you need to spend a bit more money to get where you are going. But is it practically implementable? Yes, definitely it's practically implementable. We are going to have a rough ride getting there. We heard the threats. People are going to take us to court. They can't take us to court now because there's no act. But once the bill's been through the negotiation, or through the consultation process, and has been formulated, and whatever amendments to it are going to be made are made, then it will be enacted. And at that point, there are likely to be unhappy parties who are still going to take it to court. That's fine. That's their right to do that, and it may take a while. But in the meantime, we're not sitting doing nothing. We are building the capacity and building the systems, because at some stage we got to have a national health insurance system. What can corporate South Africa do to help? Well, first of all, get rid of their own corruption. Pay their taxes, stop importing fake cigarettes, do all kinds of things like that. But on the formal market, we need to find ways, and there are some creative ways. We discussed with Busa, we discussed with the Development Bank, we discussed with other bankers and investors, ways to try and get people to have more confidence that they invest some of the money that's sitting idle in South Africa. We're not talking about foreign direct investment, we're talking about South African money that we can bring to bear. And one of the things we need desperately, and which we are working on as a result of the National Health Compact, is on our infrastructure. So when we combine the public and the private infrastructure, we have a lot more capacity to serve the public. But there are still parts of South Africa where the private sector is never going to find it viable, and the public sector has failed to provide the facilities for a whole host of reasons. And that needs to be fixed. Some of our facilities are still old mission facilities, built on old designs, badly maintained, neglected parts of them, and so on. We know where they are, and we have a plan to deal with it, but having sufficient cash up front to be able to do it and pay off our period, and changing the way we borrow money, changing the way we pay back that money, and changing the way we procure capital investments is very much on the table at the moment. And you'll know that is on the table not just for health infrastructure, but for basic infrastructure, schools, student accommodation, and everything. We need to leverage the full capacity in the government. So I won't go into lots of little detailed ideas, but there are people who are coming forward after every presentation and bringing me their CVs and saying, I want to be a part of this. I've got this massive file of potential resources that when we start to advertise positions, actuaries, economists, accountants, people who are not health professionals, but who have an understanding or would like to be involved in the NHI. So where to from here? Where we've got to go from here is we've got to fix the things that are broken. And the systemic things have got to be fixed with systemic changes, not with fiddling with the edges. But in the meantime, while we are putting the building blocks in place to do that, there's nothing wrong with a bit of soap and water and elbow grease and tightening up on all the things that are badly managed and that we haven't done well up until now. But I would like to believe that there are enough people in the country focusing forward and learning from the past rather than focusing on the past and saying we'll never get into the future. Thank you.
Baku, do you want to comment on how corporate South Africa can contribute?
Well, no, thank you for all the questions and the comments. Well, first of all, not thinking that the debate is negative per se. I think the debate is positive. Whatever the topics or the burning topics we are discussing, the debate is positive just by existing. Because this is the moment where we need to have those discussions. So I do not agree on the debate being negative just because we are raising the concerns. Yes, are there concerns? Yes, I think we all visualize how many barriers, how many hurdles are we going to face. But is it something that can be implementable or achievable? Well, it's not the first country in the world with an universal healthcare coverage. So I think that at a certain point, even if we cannot compare with some of the countries, as you were referring, but we can find examples and we can find good practices in many of those countries, even if the realities are completely different to what South Africa is facing now. And sometimes corporates can help also on bringing to the table those type of examples. Because we are operating, particularly multinationals, we are operating in many of those markets. We have lived the same processes in many of those countries we are now looking at. So we know about those examples as also you know. So I think this is what we can bring to the table: the expertise, the debate, and the experience we have had in other locations.
Lullu, would you like to make a comment about negativity?
Yeah, I think what I'm hearing in the room today, and I mentioned it earlier as well, is that we actually want this to work. We want South Africa to work, all of us that are here. Maybe we express it in different ways, but I think that is that's the one thing, and we're passionate about it. In terms of corporate South Africa and getting involved, and I can say I think corporate South Africa has failed in quite a few instances. You mentioned corruption and the fact that we didn't necessarily talk about it. I just think it didn't come up per se in the conversation today. But as corporate South Africa and being part of corporate South Africa, I can tell you that it is something that we are definitely very concerned about, and we definitely want to get involved in and we're sticking our heads out and say, listen, we need to fix this. And there's different ways in which we're doing it, and in which we're engaging. Just to get to the question around corporate South Africa getting involved with healthcare delivery and the NHI, I think there's space for everybody, and different companies are getting involved in different ways. As PwC, for example, we've been involved in some of the pilot projects in the provinces, in terms of assisting with information and knowledge gathering, etc. So everybody and every corporate in South Africa and every citizen can get involved in different ways in solving some of the challenges that we have. I think where we do need some work is in terms of trust. Nicholas mentioned, corporate South Africa has South African businesses have a lot of money. We have about 800 billion in South Africa that needs to go somewhere. We would prefer if that doesn't go out of the country. We would prefer if that stays here. There's different initiatives being undertaken by government to actually help building that bridge. There's the Presidential Infrastructure Committee. They're very involved. They have the ability to engage with different players, to engage with private sector, and to actually build capacity together. There's the PPGI, Private and Public Sector Growth Initiative, there we go, where we also, we've opened the doors. Government and private sector said, listen, we know we need to work together. And as government said we can't do this on our own. Private sector said, but we need some help and some reassurance from you to actually make it worth our while. So I think there's a lot going on behind the scenes that maybe we're not always advertising as well. And there's definitely been movement from in the last 2 years, I personally feel, in terms of the direction where things are going.
Alex, you mentioned to us quite a few challenges and problems. What are some proposed solutions that we should be looking at?
Yeah, so I think that first of all, just on the comment of negativity, I think that you have to understand in policy-making processes, and please understand, I don't work for Janssen's, I don't work for any pharmaceutical company, I work for nobody in the private sector. I've spent my life in policy, in health policy. So part of my frustration with this system is that I have seen these issues raised year after year after year, and I'm frightened and worried and concerned that everything that I see today means that in 5 years from now, I could be sitting at a meeting like this and we'll be raising the same things. Now, that's the experience to date. So there's nothing that I've seen to date that actually will change the possibility of having that discussion in 5 years. So when you look at how you deal with policy, you typically break it into two areas, a diagnostic and a set of policy options, both of which must be assessed very carefully but are quite distinct, because you can have one diagnostic but many different ways of solving the problems you come up with a diagnosis. And then those policy options must be feasible and rational and reasonable and implementable. What I'm querying at the moment is, first of all, whether or not the diagnostic has been done properly on the South African health system. And if it's not been done properly, then we don't have the right policy recommendations and we have an increasing mess. The second issue is that if we have the right diagnostic, Have we got the right policy option, and is it being assessed properly? Now, I'm raising concerns, and they are real concerns. If somebody like me who spent their life in policy says, worry about this, you should be worried. So we are currently sitting with policy proposals on the table which have no feasibility analyses, no fiscal feasibility analyses, no institutional feasibility analyses. In over 11 years of supposed work, nothing that can actually say this is logical and rational. The health market inquiry has just been completed. I was part of the health market inquiry, did a detailed diagnostic, came up with recommendations. Those recommendations recommend particular systemic interventions to change how the private sector is organized. I'm seriously concerned that those positive recommendations will not be implemented because they have been withdrawn. Many of the recommendations in that policy framework have been in the policy processes before. They were pulled out, they were removed, because we're going to have NHI, which is going to cover everybody and not have medical schemes, which is an absurdity. On the question of whether in the next 5 years we will see NHI, I don't think that there's a public sector reform that might be possible. One can create a building in Pretoria and put people in it. But whether or not we're going to see anything like what's being proposed, which will even substitute for provincial coverage and certainly substitute for private sector coverage, is a technical impossibility. So I've also had extensive engagements with National Treasury. I know exactly what their position is. I know how worried they are. The last thing they're thinking of is NHI. They are in such a hole. So the idea that's unusual in the South African NHI proposal, that we're going to raise a general tax in order to cover a covered group, is so unusual within an international context. Universal health coverage models typically involve tax increases to cover an uncovered group, not a covered group. So when we raise taxes to fund medical scheme members, we're raising taxes to fund people who are already being funded somewhere else, and we're trying to create a new method of circulating the money through the system. You know how complex that is to change the system when you can't even show that you're going to produce a more efficient result. So that's why I'm raising concerns. And I think that people really should be aggressive and assertive in holding government to account, because, damn it, we've gone through 25 years where we're sitting with levels of 10% of irregular expenditure in the provinces and the state and enterprises. Yes, we should be criticizing and we should be critical, and we should make sure that the next set of reforms that are done properly, and that people who promise stuff and say, don't worry, focus on positive things. We're working on it somehow in the background. That's not good enough anymore. We've actually got to have confirmation of stuff that's going to work, and we need government to be disciplined in doing it, and they're still not disciplined. But, so I think that there's a long way to go. I do want to make one comment just on the innovative medicine side, and a comment on what we need to look at within that framework. I do see that we have a major problem there's a breakdown between who does the innovation and who ends up with the innovative drug. Now, if I were a government doing its job in South Africa, I'd be worrying about that. Because first of all, the current incentive structure for innovative drugs and the way in which the IP framework is organized means that we are not necessarily incentivizing people to actually produce innovation in medicines in the areas where we need medicines. And what happens is that when the people who actually innovate aren't the people who end up driving the drug and marketing it at the end of the day, and that the IP framework just ends up creating a monopoly pricing framework. So, is anybody in government looking at that pipeline? No. So this is where I come down to it. Now that's a conversation, that's a hard conversation to have with pharmaceutical.
Conversation,
it's a hard one with pharmaceutical manufacturers. It's one that is needed in real policy. And when I'm being negative, I'm not representing pharmaceutical manufacturers in doing it. There are hard conversations with the pharmaceutical industry that are not happening. And that's part of the problems I'm raising, because they're not going to happen.
Okay, so unfortunately we have run out of time, so I'm going to ask each panelist to just spend 30 seconds with some wrap-up comments, please. Paco, maybe we can start with you.
Yeah, 30 seconds. Thank you very much for inviting to the panel. Many open topics for discussion, including the last one you were mentioning. three key elements in my view as Jansen. One is innovation should be part of the debate, and now is the moment for having the debate. Innovation cannot be excluded from the debate. Availability of treatments in the country is a key starting point. We cannot discuss on pricing, we cannot discuss on anything if products are not available in the country, and we need to continue working on the regulatory component, and affordability as the third element. With or without a single exit price, there are mechanisms to negotiate and to look for alternative pricing models, manage entry agreements that can make the products more affordable. So those three elements, innovation, availability, and affordability, should be on the debate.
Okay, thank you.
Thanks. Okay, my tuppence worth, other than to say thank you as well, is to say we can't sustain the current system. It will collapse and it'll implode in such a way that we will not be able to recover. So I would encourage anyone who's interested, climb in the bull ring with us and help us find solutions. We definitely don't know everything that needs to be done. There will be mistakes made along the way, but we have embarked on a journey, and I think it's going to be a rough ride, and the more people who climb in and help us to solve the problems, the better. Thanks.
Lullu?
Yeah, I think adding to what Nicholas has said, from a macro fiscal perspective, we need to rethink how we're doing things in the country, where money's going. If we start cutting expenditure in particular areas, we can't cut it in areas that will impact growth. And healthcare, in my opinion, is one of those. I think we've seen enough evidence from around the world that a healthy, productive workforce and population is actually very positive for the economy in a whole bunch of areas, and that the positive impact of that actually exceeds the cost of providing that healthcare. But what I want to say is that we need to think differently about how we do things. We don't have infinite resources. We need to work together as public and private sector to find solutions for certain of these things. And we need to realize that some of the decisions that we need to make is probably going to be a little bit painful and uncomfortable for some of us.
I think that health sector reform is complex. Health systems are complex. They do not get transformed through what are called non-incremental policies, where people go for dramatic solutions and try and change everything very quickly. They actually do involve carefully considered incremental jumps in reform from where you are. If we don't actually begin to follow that pathway, we're going to have some difficulty. Now, we've had a politically induced policy for non-incremental reform. I think that we have to reverse that, come back to facing the hard realities of our health system and work from the deepest problems first and move from there. And we have to be able to dispense with the policy recommendations that don't make sense anymore and focus on the ones that do make sense. So I think that there is a big task ahead to avoid being in this room 5 years from now saying, why are we in a worse position than we were?
Okay. Thank you. Thank you to my panelists. Thank you to the audience for participating. It's been a very robust debate. I think there will always be disagreements. That's part of us being part of a very vibrant democracy. But I think we all have the same intent and the same objective in mind. So I think that is already a good start. So thank you, everyone.